If you're a nurse or healthcare professional striving for growth, balance, and career success, you'll love The Nurse Keith Show. Hosted by nurse and career coach Keith Carlson, this podcast delivers invaluable advice to help 21st century nurses thrive. On The Nurse Keith Show, Keith explores career management, self-care, social justice, and even entrepreneurship. Through inspiring interviews and expert insights, he'll help you create a satisfying career and life. Listen and follow The Nurse Keith Show on your favorite podcast app, and you can find all the links that you need at healthpodcastnetwork.com/nursekeith. That's healthpodcastnetwork.com/nursekeith.
Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Today, we're going to hear from Dr. Lonnie Nelson. He's a neuropsychologist, descendant of the Eastern Band of Cherokee Indians, and researcher at Fred Hutch Cancer Center. But these titles really don't capture what matters most. He lost two brothers to preventable conditions, one at age 49, another at age 56. Now, he dedicates his life to ensuring Native people live to become elders. Or, that's his ultimate vision, I'll say. Here's what Dr. Nelson helped me understand. Indigenous communities have known for millennia that medicine isn't just what you prescribe or inject, often what we think of as medicine, at least in Western nations. He redefines medicine. He says that medicine is anything that changes how someone feels in this moment. It could be your grandmother's kitchen with its familiar smells, or a conversation that makes someone feel heard. All of this is medicine too. I've been learning from Indigenous communities, off and on for years now, always through relationships built carefully and respectfully. Because often when you're learning from Indigenous communities, you first acknowledge that knowledge isn't ours to take. It's shared through permission and received as a gift. Today is one of those episodes. I hope you receive it as a gift because Dr. Nelson shares his wisdom and what he's learned as a researcher, but also being part of the Native community. In this episode, you'll hear Dr. Nelson explain why patients who seem quote-unquote non-compliant are actually dealing with fractured integrity. And more importantly, how to help them rebuild that wholeness. You'll learn practical approaches that turn clinical encounters from transactions into actual relationships. He'll share his own story about research from talking circles in a housing project where people arrived and left transformed. One thing that really struck me, though, is when healthcare genuinely serves communities, which also we keep talking about over and over in this podcast, especially when it means we're serving communities that have survived medical hardships, forced sterilization, unethical experiments, and centuries of broken promises. If you think about what kind of care these communities need, it actually becomes the kind of care everyone deserves. Not despite the history that I just mentioned, but because of what it teaches us about trust, respect, and real partnership. Dr. Nelson will also tell you directly, in every healing relationship, you are the servant. Not the expert with all the answers, but someone learning how to be helpful in ways your patients actually need. And maybe that's the main takeaway from this whole episode. What does it mean to show up not as an expert, but as a servant? Well, I want you to hear it directly from Dr. Nelson. Here we go. All right, Lonnie, welcome to the show. Tell me about yourself.
Descendant of the Cherokee Indians by way of the Melanesian communities in Rose Hill, Virginia, and Hancock County, Tennessee. I'm a clinical psychologist by training, and I mostly conduct research in American Indian, Alaska Native communities to address whatever disparities are most top of mind for the communities at the time. We work together to come up with what sounds like decent solutions from their end, and then try and get NIH to fund research to evaluate whether or not those solutions actually work.
I can hear how centered around the community you are. And you said, well, let's see what's important to them and then see what they think will work, compared to sometimes I hear, here's what I think will work. Let me go test it on a community if it works or not. So there's a change in that perspective. It's helpful for me to think about your origin of what drove you to this work in clinical psychology. And I know family is part of that. Could you share a little bit about that?
Yes, I'm one of 4 children and my immediate family, and I'm the youngest. My oldest brother passed away at 49 from complications of diabetes, which would have been modifiable by lifestyle and behavior change had he been able or willing to do those things, but he was not. And then my next oldest brother passed away at the age of 56 as the result of multiple strokes, which also could have been, modified again by lifestyle and behavior changes. And just seeing the way a person lives their life and the way that they view their health and their life path can have really significant effects on those they love and that care about them. It really gives me a starting place to think about how I approach those kinds of things in my own life. And then also as an extension professionally, I try not to separate my work professionally from how I view my own world and my relationships and so on. And I think one naturally leads to the other.
Yeah, we all have a deep connection to our family, our culture, or community that drive us to the work that we're doing. I do agree, just as we probably have a false dichotomy of mind and body and separate it out, we separate out personal and work when it's hard to separate out something like that. Thinking about how much that affected you, and a part of that you carry with you, and some of those factors that you mentioned, modifiable factors, is what healthcare is supposed to focus on. We, at the very least, talk about them to our patients. And then when they're not able to do it, we, at the worst parts of ourselves, we say non-compliant. The best, quote unquote, is non-adherent. And we leave it at that. So part of your work is reframing that and rethinking about it. And one core part that came out is culture as medicine. When we talk about Native communities with high rates of alcoholism and other quote unquote lifestyle factors, how do you even start the conversation and talk about some of these lifestyle factors with Native communities?
So, as part of my general professional life and personal life, I teach workshops on indigenized motivational interviewing. And I'll just give a brief snippet on where that comes from and the general approach to having those conversations. First of all, motivational interviewing was popularized by a psychologist by the name of Bill Miller. He was at the University of New Mexico at the time. And in developing the approach to talking about behavior change and building motivation for changing one's behaviors, he worked pretty closely with a roadman by the name of Ray Daw, who's still very engaged in Native behavioral health, mental health circles. And so the roots of motivational interviewing are actually in Native culture. And they actually come from how Native healers interact with people that they're trying to affect positive change with and to help live a healthier lifestyle. And so the way that it's usually taught in Western medical settings is pretty divorced from that and can be somewhat manipulative and can be shaming, guilt-driven, and so on. And so I try to present it completely disconnected from the way it's taught in the Western world and bring it back to those roots that really flow from Native culture. And key to that approach is, I'll just preface this by saying that there are lots of different Native tribal cultures and affiliations and histories, oral traditions, and they all, of course, have their own specific traditions and values and so on and so forth. But there are some cross-cutting things that we have in common. And one of those is we value the sense of self-governance, self-determination, and we value a property that I refer to as integrity. Now, I don't mean moral uprightness or correctness when I talk about integrity. I'm talking about like the second definition of that word that means the state of being whole and undivided. So how you might talk about a bridge having structural integrity, right? It doesn't have any parts of itself that are working against other parts of itself, right? It has sort of a unified sense of existence. And so I encourage folks who are going to be engaging in conversations with their relatives about behavior change and what behaviors aren't in line with a unified sense of who they would like to be as a person in the world, and to not be separate from their relationships and not have their behaviors conflict with their relations, both within themselves and with other relatives, and to talk about the various behaviors that they have in that context, right? Because nothing that we do is divorced from the context in which we live. Right? And so to think about some potentially problematic behaviors, you mentioned alcohol use or drug use, and even dietary and exercise habits, right? I mean, all of these exist within the context of our relationships. And they're either in support of who we want to be and how we want to show up in those relationships, or they're not, right? And if you ask the vast majority of Native people, what are the three most important things to you in your life? One of them is going to be their family. And given that relative importance with regard to other dimensions of our life and our path through life, you then have to ask them about how certain behaviors that may be presenting problems for them fit in how they view their role in their relationships, and to think about how they can move toward having greater integrity with regard to how they want to show up in those relationships and who they want to be as a person and a member of those relationships, and the reciprocal flow of emotion and everything that happens within those and within that context. And oftentimes people who are engaged in an addictive cycle don't automatically think of that, and don't automatically think of how the addiction is affecting their relationships. They don't automatically go there for themselves. But if you ask them those questions in an open-ended and non-judgmental way, you can have some really productive conversations with folks and, just make it clear that you're not trying to change them or make them change themselves so much as just to consider how they want to be in those roles.
Yeah, I love it. I do think a recurrent theme that I get when I'm talking to Native communities is the relationship part of this work. For example, when we talk about food as medicine, healthcare has an understanding of that. Eating this food will make me feel better. That's what food exists. Just when I say, you're laughing because, you're like, what's wrong with what I just said? There's actually a lack of insight. When I talk to Native communities, there's prosody. It's probably the biggest principle or value with anything that you're in relationship with, including food, that sometimes people have a hard time understanding. So bringing that value into, or understanding into motivational interviewing without manipulative. We use tools and techniques so we can convince people to do what we want them to do, or like working together, some goal together of it. I know you have actually several domains of expertise. As a clinical psychologist, do you have a good way of framing it for folks who don't think about it that way?
Yeah. So when we use the term medicine in conversations in Native communities within our own cultural context, the word medicine doesn't refer to a particular substance or prayer or song necessarily. Medicine is anything that can change the way you feel and the way that you are feeling at that time. The smell of walking into your grandma's kitchen changes your emotional experience. That's medicine. So when we refer to something being good medicine or being medicine, it's because it has the ability to change how we feel.
Wow, that's profound in itself.
Yeah. When you say the phrase culture is medicine or food is medicine or water is life or any of these popular sort of catchphrases that you hear spoken around native health practices, you have to understand that the medicine that's being referred to is that definition of the word medicine, right? It's not antibiotics.
Yes.
Necessarily.
Yeah,
Like immune function, and
Yeah.
it's entirely possible. And we know psychoneuroimmunology is a thing. That's one of the things that you have to keep in mind when you hear people use these phrases, is that we're talking about medicine in a more holistic understanding of what the word means to us. So participating in cultural practices and in traditional activities, these give Indigenous people a sense of belonging and pride. And those emotional experiences may be somewhat different than the day-to-day experience of living in Western culture as an Indigenous person. And so being able to reconnect with those traditions and those practices has a very tangible emotional impact for us. And at certain points in my life, even that was a painful experience. Right? I had been away from traditional culture for a very long time. I wasn't raised traditionally and had to come to terms with the fact that I wanted to understand that aspect of where I come from and wanted to engage with it. But in order to do that, had to understand what I didn't know. And that hurt, because it was painful to know that there was a part of me that was unclaimed out there somewhere. Right. In the end, I've adopted some things into my world view and my understanding of myself and my path through life that have ultimately been very helpful and have steered me onto a more healthy path, I think, in many cases. It's not always painless.
Thanks for sharing that. As you've integrated your identity more, when you imagine a Native individual who's carrying centuries of specifically medical trauma, if you think about forced sterilization, unethical research, so many broken promises, and you have the short encounter to build trust, what does that conversation look like? And what are the words, tone, anything that can bridge that gap when people are meeting for the first time?
I teach about building rapport, which I think is what you're asking about, is that you need to just take some time at the outset with no agenda other than truly getting to know who they are and letting them know who you are. And truly without an agenda. Like you're not trying to get anywhere, right?
I'm going to get you. What's your job? What do you eat? Who do you live with? All right. Do we do our job?
You want to find out who they are as a person, what relationships they're in, where they would like to go, what's important to them in their life, and to share those things about yourself and to be as open as you want them to be. And I think that especially for healthcare professionals, that's not an automatic thing. Like when I was in clinical practice, I had to specifically make myself not play the role of a counselor, of a psychologist. And knowing that I have some tools that I'll eventually bring to the interaction that come from that training, but not to be that role, but to be myself in that role and to be authentic in the interaction and to take the time at the outset to just establish a basic understanding between two human beings and to get a sense of each other and to allow them to get a sense of who I am as a person as well. That doesn't always immediately happen in Western healthcare settings and interactions. And that's probably the one most important thing that you can do to establish rapport and trust quickly is show the vulnerability that you are hoping to share with them.
Yeah, this seems true for so many cultures. This is the best way I've heard it framed what you just said. Maybe it's because you're a psychologist, just reframing a lot of things for me, and it's super helpful. But this separating yourself from your identity as a professional, because we so often just come to a space saying, I'm the doctor here. And then when you ask questions, it's in service of a different purpose. Like, I'm a doctor, asking about yourself, so I know when I give you a prescription for insulin, you have a fridge at home because I want to know if you're homeless. So, because the purpose of understanding your housing status is so that when I prescribe medication, I can inform that decision rather than, wow, let me just connect with you as a human, be there with you. And then, as you said, bring in the tools that I know I have accessible to me through my training to see if we can somehow support you in whatever way it's possible. That separation of the tools that I have and the skills that let me start the encounter is just almost equalizing the power a bit, potentially. Is that essentially capturing what you're getting at?
A big part of counteracting that automatic mistrust of the medical industrial complex is demonstrating that you're a human, right? That you're a person, that you're not a role.
Yeah.
Right? You have a job, sure, but you are a person who has a job first.
Yeah.
Right? And you have some tools and skills and knowledge that you gained because you went to school to be able to do this job, but you're a person engaged in this relationship with them. And that your intention is to be as helpful as you can be.
Another principle that I've heard, I don't know if this is connected to this moment, zooming in on, is the transactional nature of relationships. Sometimes that's probably the dominant culture in Western culture, and it's true in healthcare too. I'm providing a service because you paid for health insurance and you're coming here and you paid a copay, and here's the fix that you're coming for. And then give me a survey if I solve that problem in the way that you liked. It could be more transactional, I don't know. But there's a tension there of you're trying to create these places of connection in that larger model of transactional system that we're in. I'm wondering, is there anything else that helps build trust in this kind of system that people are part of? Often the dissonance between what people are hoping for and how the system is makes it really hard for everybody involved.
Step one is being a human in the interaction, right? Being a real person and not being a role. That goes a long way toward escaping the transactional pattern of interaction, right? Because you have a job. Yes, you are there to do a particular thing for them, but you want to try and be helpful to them in ways that they are comfortable having you be helpful and in ways that they want you to be helpful. And you need to understand what those are and not presume that the way you want to be helpful is what they want. So the way to escape the transactional nature of the interaction, as you framed it, is really to take that approach of truly being patient-centered or client-centered or person-centered, to come into the interaction presuming not to know anything about them, their situation, or what they want. You're not assuming you know that.
Yeah.
And so your first task as a person going into this relationship is to establish that you're a person in a relationship and to find out what they want from it. And then talk about what parts of what they would like from the relationship you can provide and what parts you can't, and how you might be able to try and help them get the parts you can't personally provide. But it really is, it's more reciprocal. It's more of a relational model, and it's less of the expert treating a condition than it is a person engaged in trying to be helpful with whatever tools they have at their disposal.
Yeah. I know it's not true for everyone. And I sometimes understand this idea of designing for the margins. You know, if you create a system that's truly relational for Native communities, it's like everybody would benefit from it. A lot of people are not satisfied with the healthcare system as it is because they're seeking relationships, and often they get a service for a problem that maybe or sometimes helps, sometimes doesn't. It's really a responsive care that we provide to some patients versus really creating a relational system because everybody can benefit from it.
Privilege of working with Their name is Itai Jeffries. One of the things that they were fond of saying was that our culture is good for everybody. Like it's actually healthy for everybody to participate in our culture. So
Yeah, no, I love that. Part of your approach that you brought up earlier was you describe it, if I read it right, as a servant to the communities you work with. Do you have any examples of when you flipped that traditional researcher subject relationship? So when you showed up at a community, they said, no, that's not what we need, and redirected the question that you were seeking to answer, and how that changed?
yeah, so probably the best example came out of my wife's work, actually, more than mine specifically. My wife is also a clinical psychologist, and she works at Harborview as clinical care through the addictions service. But she's a harm reductionist. And we actually got to know each other back in 2013 because she had been doing some community-based work with a Housing First program here in Seattle at 1811 Eastlake. At the time, they were trying to determine what the residents there felt would be helpful for them in terms of just healing and improving their quality of life and so on and so forth. And a couple of things that she discovered were 38% of the people who lived in the building reported Native heritage, which blew her away. She was like, there are only 1.7% of the population in the city. How are they 38% of the population in this permanent supportive housing?
Yeah.
And that they wanted more Native representation in the staff at the facility. And that they wanted access to traditional cultural practices. And when she and her team asked what practices, they were like, talking circles. She was like, what's that? And so she actually contacted me to ask, because she had heard that I was doing a project using talking circles as a vehicle for employing motivational interviewing for stroke risk reduction at the time. But anyway, she was like, so these folks, they say that they want talking circles at this facility, and I was just wondering if you would be able to come and provide that, at least on a trial basis, to see if it's actually what they want. And I was like, so this is a Housing First project where folks are not necessarily sober, right?
Yeah.
And she was like, that's correct, yeah.
Yeah.
I was like, I don't think you're allowed to do that. I don't think that you can do ceremony with people who are intoxicated.
Yeah.
That's just not ever been part of what I learned.
Yeah.
And so she actually arranged for me to meet with 3 Native healers from the community here. And me and her sat down with these 3 guys. And we talked for like 3 hours about how this could be made to work and what kinds of safeguards would have to be in place and so on and so forth. And at the end of the 3 hours, they gave me permission to try it. And so I started every couple of weeks. I would go over on a Wednesday around 11. And in one of the activity rooms, we would hold ceremony and do a talking circle with these folks. And the first time, people who showed up were largely intoxicated. The second time, only about half of them were. And by the time we went around and did the personal smudging of all the participants, the vibe in the room was very much like that of any other talking circle I've ever been in. People were very solemn. They were very sincere. They were listening with their hearts. They were completely transformed by like the second time we held one.
Yeah.
And so
Wow. Yeah.
it turned out they knew exactly what they wanted. They asked for it when it was given to them that served the purpose they wanted it to serve. And so it turned into a whole project that we did for the ensuing, 4 years, 5 years. And my experience of thinking that the solution was going to be one thing when it turned out to be something else. Well, what I thought was you can't do ceremony with people who are intoxicated. And that's not going to work. And it's going to potentially be harmful. And what I ended up finding out was, no, they knew exactly what they needed. They asked for it. And when you gave it to them, it was dramatically helpful.
I love it. And a recent episode, we talked about Islamic trauma healing, really focused on using stories from the Quran as a way of healing from pretty significant community trauma. And one question that I brought up here may be relevant here too, when you're responding to community needs, and you as a researcher are contending with some of these bigger topics about, oh, great, Lonnie, can you put that in a playbook? And then let's, share it with everybody so then we can have mass talking circles everywhere. So a sense of like, oh, if it solves for one context, we need to be able to find out the core and spread it across.
Response to that is there are still places where that is being done on a regular basis. You don't have to create something new. You just need to direct people to where it's already taking place.
Yeah.
So the reproducibility is in the cultural tradition that the facilitators of talking circles draw on when they're facilitating those ceremonies. That's reproducible. They know how to do that. They've been taught how to do that. They will do it correctly. All you have to do is direct people to go and use those resources that exist.
Yeah. No, I like that. For that scalability portion of it, is that a question that you come across, or how do you respond of, hey, if it works for this center, can you do multiple classes across the state so then we can address this problem?
So when we launched the project that eventually grew out of those initial experimental sessions, we partnered with the Seattle Indian Health Board. And we worked with them on developing an actual protocol for how to do this. And what we had talked with them about was having an evidence base so that they could bill existing payers for providing this service because it had some data to support its efficacy, right? That it was helpful in some way for this population.
Yep.
And so I think that maybe that is potentially a better route to increasing the availability and the scalability of the intervention, is getting existing payers to recognize this is a valuable service and getting them to be willing to reimburse for its provision, just like they would for group psychotherapy or any other similar approach for a similar population.
Yeah, truly thinking of what is culturally responsive care looks like at every level, including reimbursements, not just at the provider level. Shifting topics a bit, because I know you are doing some research on brain health. You're studying urban native elders, I believe, with Alzheimer's. What are you discovering? Because it's technically an invisible population because it's not well documented that I see. What are you learning from this?
So one of the things that I often get to educate people about is that if you look at the American Indian Alaska Native population who are age 65 years and older, over 86% of them live in urban areas. So very few actually reside in reservation communities anymore. Now, if you think about most urban areas in the United States, that's a very different risk landscape than a reservation community or even most rural communities, right? There are a lot more like preventive care and specialty care services available in most urban environments than there are in most rural and frontier environments. And you think about the reason folks found themselves in these urban environments. A lot of times their children have gone to work in the cities and grandma and grandpa come along to help out with childcare. It's very much this intergenerational model that they're just bringing with them when they come to the cities, right? And so that's one of the pathways. Another pathway is that you have differences in education between those who migrated to the cities 20, 30 years ago versus those who didn't, right? And so you have this sort of self-selection process when you sample from an urban environment and you're looking to talk with native elders. So We've only just recently completed all the data cleaning and reconciliations and getting all of the scoring, double scored and double entered, and all of the methodological things that you have to do to make sure you have good quality data. One of the first things that we did, one of my team members from the Seattle site for this study it's a 5 sites: Anchorage, Seattle, San Bernardino, Phoenix, and Oklahoma City. And the site lead from my Seattle site actually just finished their master's. And for their thesis, they did an analysis of the NIH Toolbox for Cognition data. And they asked me what I thought would be helpful. And I was like, as a neuropsychologist by training, we really need norms for this population because we don't have any. We don't know what normal performance is.
Yeah.
And so if you could just do a basic analysis, breaking folks up by sex assigned at birth and age, and if we could get uncorrected standard scores for 5-year age groups for males and females, that would be hugely helpful as a first step, right? One of the first things that we saw when we did that is that their crystallized cognition composite score was about half a standard deviation above the population average for the United States.
Yeah.
Their fluid cognition composite score was about a standard deviation and a half below the average over all the folks. Now, for those of you who aren't neuropsychologists, crystallized intelligence or crystallized cognition is fund of information, it's vocabulary, it's like reading ability. These are the things that are highly correlated with degree of educational attainment and don't typically go away as a result of injury or pathology. So a person, myself, I have a PhD in clinical psychology. If I were to get a brain injury on my drive home this afternoon, please creator, no. But should that happen, I would probably not have much of a change in my vocabulary. I would probably still be able to tell you who Barack Obama was. I probably still would be able to tell you a number of historical facts that I've learned over the course of my life as fund of information. What would change would be my ability to regulate my attention, my ability to encode and retrieve new memories, my ability to process information quickly, my speed of mental processing. Those are fluid cognitive markers. Whereas the crystallized stuff is the stuff that would stay intact even if I sustained an injury. Right. So what we see is that the urban native elder population actually has a pretty high, 41% of our sample had attended some college, which in the other epidemiologic cohorts that are reservation-based, you did not see. And people just assumed there was low educational attainment in this population. Not the case. If you go where most of them actually live, which is urban areas, and you sample from there, you see that there's actually higher than average educational attainment. And that's why you see that higher level of crystallized intelligence. Now, the reason you see the lower average level of fluid cognitive composite scores is because there's such a high disease burden and injury burden in this population. 34% of our sample endorsed lifetime history of traumatic brain injury with alteration of consciousness and post-traumatic amnesia.
Wow.
So that's at least mild to moderate in severity, right? And just for context, when I was working for the Defense and Veterans Brain Injury Center back in 07, 08, we documented a prevalence of returning troops from theater of operations in the Middle East at 23% had experienced a brain injury while on deployment. This is like 10% higher lifetime prevalence. So there's a very high injury burden. There's about a third of the population has type 2 diabetes. The prevalence of hypertension, considerably higher than the mainstream population. So the emerging picture here is of a population that really tried very hard to succeed in this world. They went for the educational attainment. They put in the effort. And there are just such historical and social forces impose such a high degree of disease burden. Brain health is difficult to maintain into their advanced ages. So that's the emerging picture that we have at this point. With regard to substance use and things like that, we do see a significant prevalence of that, but we also see it in the context of a significant prevalence of depressive symptoms and symptoms of post-traumatic stress disorder.
Yeah.
And so we're not seeing just substance use or substance abuse or misuse. We're seeing self-medication. So this is a sample of folks that are trying to medicate a pain that they don't have another way to treat. And so I guess that's the emerging picture from the data.
Exciting to think about because there's actually so much information where, there's just a lack of understanding of what's happening, specifically brain health. I have 2 questions to wrap up this interview. One, maybe micro, one, maybe macro, if I say that right. I believe you also said your ultimate goal is ensuring every Native person can live to become an elder. When you imagine success, what does that world look like to you?
See a generation of healthy Native elders who just age into advancing age just as healthy as any other population.
Yeah.
I would like to see them not dying young.
Yeah.
Life expectancy, we're catching up, but we're not quite there yet. We still have about an 8-year on average lower life expectancy than non-Hispanic whites, for instance.
Yeah.
Throughout most of the country. There are some exceptions. Some geographic regions doing better than others. But, we're making gains, but we're not quite there.
Yeah.
I mean, I would just like to see folks not dying younger than their peers of other racial and ethnic groups. I would like to see folks having rich relationships with their grandkids, passing on a sense of who we are as our individual cultures and traditions, and being able to transmit that knowledge to the next generation so that they can then choose how they want to live those traditions for themselves and then become healthy elders themselves going forward. That's what I would like to see. When that happens, I'm going to retire. I'm just going to go and do woodworking and make bows and do pottery. And
I want that for you. Yeah. Let's make it happen just for that vision for yourself. This is the micro question. So getting concrete of people who are hopefully imagining that world, want to work towards it. If you have a clinician who's listening to this episode and thinking, I want to do better, but I don't know where to start. We talked about a few things, but what are 3 specific things they can start doing next week that you feel like would be valuable?
Forget your role when you walk into the room with your patient. Remember who you are as a person. Try and find out who they are as a person and find out how they want you to be helpful. Remember that you're a servant in this relationship. And your job, if you have one, is to try and be helpful in whatever way your toolkit allows you to be helpful or enables you to be helpful. But the person that you just walked into the room with, are the ones telling you how they want you to be helpful. Listen to that and try and enter into the relationship on their terms.
That's beautiful. Thank you so much, Lonnie. Thanks for joining us today.
Absolutely. It's my pleasure.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized by topics, countries, themes to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.